Good morning, everyone, and welcome to the last webinar of the National Institute for Occupational Health, the NIH. It's the NEDLAC and a COVID-19 Legacy webinar series, and this particular series is being offered and presented in partnership with NEDLAC, the National Economic Development Labour Council, supported by the Compensation Fund. And we have as a topic today for our webinar, the update on long COVID. Whilst the intense period of COVID and all the measures that had gone with that has certainly passed. However, there is elements, and in particular long COVID, that we would need to be aware of from an occupational health and safety point of view for our workplaces. And we have three distinguished speakers, Dr. Wasila Jasad, Dr. Lyle Murray, and Dr. Lucas Mosidi. I am going to now immediately proceed to ask Dr. Wasila Jasad to open her particular slides and to get ready to present from her side. You have seen the on the pre-webinar slides the profile of the three speakers, and I'm not going to go into too much detail with regard to introducing Dr. Wasila Jasad, but she has been active in our webinar series, and we are very thrilled to have her again on today's one. And with that note, I'm going to pause and hand over immediately to Dr. Jasad. Please proceed.
Thank you so much, and good morning to everyone who's taken the time to join this important webinar. My name is Wasila. I'm a public health medicine specialist. I am presently working for the National Department of Health TB cluster, but during COVID, I worked at the NICD, where I managed hospital surveillance for COVID-19. So as a background, while we were collecting data on hospital admissions for COVID-19, we realized that the issue of long COVID was going to be upon us in no time, given what we were seeing in other countries. And we established a study to recruit participants and follow them up over 12 months to determine the presence of long COVID. So I'll be sharing a little bit with you on that study. So first, let's just talk about long COVID. I mean, it's been known by a number of different names, most commonly long COVID. The WHO penned the term post-COVID-19 condition, and colloquially it's been known as, people with long COVID have been known as long haulers. But the WHO definition for post-COVID condition is a condition that occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. We know from studies across the world that conservatively about 10% of people infected with SARS-CoV-2 may be affected by long COVID. And in some studies, as many of 60% of COVID survivors experience long COVID at least during the first year. And studies with longer follow-up periods are showing us that people continue to have persistent symptoms 2 and 3 years after having acute COVID-19. We think that the burden of long COVID in South Africa is quite significant. If our SARS-CoV-2 antibody seroprevalence is 90%, that means from the seroprevalence surveys, 90% of people have evidence of having had previous COVID-19. And so extrapolating that for our population, over 5 million South Africans are likely to have been affected by long COVID. So we also know that over 50 symptoms have been reported for long COVID. Most commonly reported in studies are fatigue, shortness of breath, cognitive dysfunction, which is known as brain fog, joint and muscle pain or weakness, headaches, coughs, chest pain, sleep disturbance, depression, and anxiety. We also know from evidence presented in studies and from patient advocacy groups that the consequences of long COVID are quite significant. It affects people's health with persistent and fluctuating symptoms, having debilitating impacts and needing ongoing rehabilitation and medical care. It affects people's work and their ability to return to work safely because of their symptoms. We need to look at what their abilities are compared to their work demands, and trying to manage some of the attitudes at workplaces for accommodating return to work. And also we know the consequences, the social and economic consequences and the financial impact on the individual and society, the social attitudes to people with long COVID, and the ability to access social security systems. So I'll tell you a little bit about our study. We aim to determine the prevalence of long COVID in South Africa, to estimate what the risk factors are for developing long COVID, and to characterize the impact of long COVID on people's quality of life, their occupation, and healthcare utilization. So we designed a quantitative longitudinal cohort study working with ISERIC, which is an International Severe Acute Respiratory and Emerging Infections Consortium. 10 different countries use the same protocol, so we're also able to compare findings across countries. Over 5,000 people were recruited onto the study and followed up, and they were recruited across all waves. The first wave, the Beta, Delta, and Omicron wave, and those were hospitalized and non-hospitalized patients. We adopted the tool from ISERIC, and we did follow-ups at 1, 3, 6, and 12 months after the patient had COVID-19. And the follow-ups were done by telephonic interviews that lasted about 15 to 20 minutes. The study was funded by the Gates Foundation, and we received ethics approval. So I'll share with you some of the results of the study. We had recruited 5,147 participants. Almost 4,000 were hospitalized, and just over 1,100 were non-hospitalized. The median age was 49 years in hospitalized and 37 years in non-hospitalized participants. Most people were in the 40 to 64-year age group, and it differed. So there was younger people in the non-hospitalized group. Most people recruited were females. And then we had 28% white, 52% black, about 10% colored, and 6% Indians recruited. And 40% of participants had no comorbidities, 30% had one comorbidity, 19% had two, and about 11% had 3 or more comorbidities. So when we look at the number of symptoms that people complained of, at the end of the period, 61% said they had no symptoms at 12 months. 23% had 1 to 3 symptoms, and 16% had more than 4 symptoms. Now, this shows you the percentage of participants who had symptoms, comparing hospitalized and non-hospitalized participants, and over the different time periods that we contacted them. So amongst all participants, 82% had symptoms at 1 month. This reduced to 49% at 3 months, 39% at 6 months, and the same at 12 months. Among hospitalized participants, 82% at 1 month, 54% at 3 months, 47% at 6 months, and 44% at 12 months. And amongst non-hospitalized participants, we only recruited them at 3 months. So 32% had symptoms at 3 months, 19% at 6 months, and 19% at 12 months. So what this shows you is that hospitalized participants were more likely to have persistent symptoms than non-hospitalized participants. It also shows you that the proportion of people reporting symptoms decreased over time, but that decrease was most evident in the first few months. But then from 6 to 12 months, the percentage who still had symptoms did not change very much. This shows you the percentage who had symptoms, comparing them by age and sex. So overall, 40% of those who had symptoms were females. So among females, 29% of 18 to 39 years had symptoms, 46% of people 40 to 64 years, and 56% of people over 65 years had persistent symptoms at 12 months. Among males, 25% in the younger age group, 40% in the middle age group, and 43% in the oldest age group. So what you can see here is that females were more likely or had a higher proportion of reporting persistent symptoms than males, and older people were more likely to and had a higher proportion of reporting persistent symptoms than younger patients, and that was true for males and females. So when you look at the most frequently reported persistent symptoms, there were slight differences between hospitalized and non-hospitalized participants, but amongst hospitalized, the most frequently reported symptoms were shortness of breath, fatigue, headache, chest pain, and joint pain or swelling. And particularly for shortness of breath and fatigue, well over 20% of people had those symptoms. Amongst non-hospitalized patients, the most frequent were fatigue and shortness of breath and headache, although they were in much lower proportions. We then did a multivariable analysis of the risk factors for long COVID. So this one looks at all the characteristics of the participants and tries to determine which ones have a higher likelihood of resulting in participants having long COVID. And so what we found is that the oldest age group, over 65, were more likely to have long COVID. Females were 27% more likely to have long COVID than males. And non-Black, so whites, Indians, and coloreds were more likely to report long COVID than Black individuals. People with a comorbidity were 16% more likely to report a long COVID. And when you had acute COVID, the number of symptoms you complained of was important. And so people with 1 to 3 symptoms were 37% more likely to have long COVID, and people with 4 or more symptoms when they had COVID were 2 times more likely to report long COVID. Long COVID was also dependent on COVID severity. So compared to people who were not hospitalized, those who were hospitalized with no oxygen had a 59% higher risk of long COVID. Those who were hospitalized and received oxygen had an 81% higher risk of getting long COVID. And those who were hospitalized and needed ventilation or ICU had a 2-fold higher risk of getting long COVID. And long COVID development also kind of dependent on which variant of SARS-CoV-2 people were infected with. So compared to the first variant, D614G, people infected during Beta, Delta, and Omicron were less likely to report persistent symptoms. So that's saying that the people in the first wave had the highest likelihood of reporting persistent symptoms. But particularly in the Omicron wave, there was a much lower chance of reporting long COVID developing. We were also interested to see what the persistent symptoms meant for needing hospital and medical care. And so what we found was that 2,402 people, or 47% of all participants, reported that they needed to seek GP care. Most were in the first month, 41%, with 13, 8, and 12% in the other follow-up periods. In terms of hospital admissions, 728 participants, or 14% of participants, reported that they had to be readmitted to hospital. And this was quite evenly spread, with 4% in the first month, 5% in the 1 to 3 month period, 3% in the 3 to 6 month period, and 6% needing readmission in the 6 to 12 month period, showing you that there was quite a significant need for healthcare utilization among participants. We asked about the medical complications that people had after COVID-19. 62 people reported having a heart attack after COVID-19, 80 people had a stroke, 217 had a clot in the lungs, 53 had a deep vein thrombosis or a clot in the legs, and 263 reported that they had kidney problems. And most of these complications were reported in 0 to 1 month, in 1 to 3 months, and then in 6 to 12 months. We also asked questions about people's quality of life, and those who reported worsened quality of life in the following spheres of life were quite significant. And so 10% reported that their mobility had worsened, 11% said their memory had worsened, 1% said that their ability for self-care, daily activities had worsened, 5% said their vision had worsened, 2% said their hearing had worsened, and 1% said their ability to communicate had worsened. And finally, we asked questions about people's occupation. So after a year of follow-up, 319 people, which is 5% of participants, reported that their occupation had changed after COVID-19. And among these 319 people, 144, which is 45% whose occupation had changed, reported that the change was due to persistent symptoms after COVID-19. Others said that they wanted a change, they were made redundant, they had other health problems, their hours were reduced by employees, or they preferred not to say. So in summary, our study showed that there was a high proportion of patients with persistent symptoms up to 12 months post-COVID-19. While there was some improvement in symptoms over time, our study showed that between 6 and 12 months, there was not much change. So the people who continued to have persistent symptoms at 6 months had not much resolution beyond that. And I think the figure of 44% of hospitalized and 19% of non-hospitalized participants with persistent symptoms at 1 year after COVID-19 is quite important. The risk factors we described are older age, female sex, non-Black race, comorbidities, higher number of symptoms during acute illness and severity of COVID-19, all having a higher likelihood of having long COVID, and lower odds in the Beta, Delta, and Omicron wave if they were infected in those waves. And we showed no association with individual comorbidities, but just the presence of comorbidities overall. But that might be because of the number of participants recruited. If we had a bigger study, we might start to see which comorbidities were more likely to result in people having long COVID. Our study also showed that there was an increase in people health seeking after COVID-19 because of their persistent symptoms and complications, and that there was a significant impact of long COVID on people's personal and work lives. We've been working with other colleagues in other countries and described in a paper the significant impact of long COVID in low and middle income countries. And I think there are some particular challenges in low and middle income countries. There are few studies that have looked at the burden. There's not enough research or surveillance infrastructure. There was insufficient testing and underreporting of SARS-CoV-2 in the first place, which would make diagnosis of long COVID difficult. There is not enough capacity for multidisciplinary rehabilitation services, which are required by people with long COVID. And our health systems are constrained. We have under-resourced primary healthcare services and many competing health priorities. We also have read that chronic disability resulting from long COVID is likely to place an additional burden on an already overstretched healthcare resources. I think the other concern is that there's a low coverage of social protection measures in low and middle income countries to mitigate the negative impacts of the pandemic. And the other concern is that there was an inequity in access to vaccines and a lower vaccination coverage in low and middle income countries. And so while some studies are reporting that vaccination reduces your risk of getting long COVID because it reduces your risk of getting COVID in the first place, the problems of inequity in vaccination would be a challenge for our setting. And in addition, there's also a limited access to novel COVID-19 therapeutics in low and middle income countries. Antivirals that are available in high income countries are not available here. And so when we do have long COVID candidate treatments, it may be a challenge to access them in our settings. The recommendations we made from our study is that we urgently need to address the health service needs. We need better patient messaging and support groups for participants because many of them do not need acute or chronic health services, but they need reaffirmation and they need support. We also need to ensure that we have guidelines and the guidelines are known by healthcare workers, and healthcare workers are better sensitized, especially at primary healthcare level, to recognize long COVID. It's a difficult diagnosis to make, and people often overlook it. And when they see people with chronic and non-specific symptoms, they don't think of long COVID. We also need to have better multidisciplinary health services available in all provinces. At the moment, I know of very few in the public sector that take care of people with long COVID. And of course, because we know COVID vaccination reduces your risk of getting COVID, we must ensure that people are vaccinated and have had their boosters, particularly those at highest risk. In terms of occupational health services, we need to really define what the employment rights and benefits are with regards to long COVID. Employers need to look at gradual return to work and looking at work or task reallocation based on the symptoms people have, and also looking at access to benefits like healthcare, sick leave, and financial support. The NICD wanted to do more than just a study, so we developed a web page on the NICD website, and I urge you to look at that. It's available on the NICD website, and this provides information about long COVID, and there are patient testimonials and short videos on long COVID experts to help participants. We've also published a number of publications. We've worked with the media to have articles and news reports covering long COVID. We've presented at conferences, and we've supported the National Department of Health COVID Clinical Task Team to develop long COVID guidelines and to do training of healthcare workers. We've also supported the development of advocacy groups and support groups through advocacy organizations, and a long COVID support group was established in South Africa. So I'd like to acknowledge all the researchers who were involved in the study, NICD, ICERIC, and the Gates Foundation, and the National Department of Health, but particularly all the participants who gave of their time to provide these insights so we could better understand long COVID. Thank you so much.
Thank you very much. That was Dr. Wasila Jasset, who works for Genesis Analytics and is seconded at the moment to the National Department of Health, where she provides technical support to the National TB Program. I'm quite interested to note in her profile, short bio sketch, that she's passionate about knowledge translation. I'm thinking of connecting with her about that even for our own purposes here. So thank you very much, Dr. Wasila Jasset. Just a quick announcement again, please, if you've got questions for our speakers, link to the content of their presentations today, please type them there in the question and answer box, and you will have the speakers and our non-speaking background panelists looking at your questions and answering them there. Thank you very much. Our next speaker is Dr. Lyle Murray, and Dr. Lyle Murray is a lecturer at the University of Witwatersrand and is a consultant in infectious diseases at Charlotte Maxeke Johannesburg Academic Hospital in Johannesburg. He's a clinician scientist with particular interest in immunology, infectious diseases, and the impact of HIV infection thereon. So with that very short, quick introduction, I hand you over to Dr. Lyle Murray. Please proceed. Thank you.
Thanks so much. And good morning, everyone. And thanks so much for joining us this morning to talk a bit about long COVID. So to understand a little bit about long COVID, we obviously need to understand a little bit about COVID itself. And as you are all aware, at the end of 2019, this novel coronavirus was identified in China. It rapidly spread, resulting in an epidemic throughout the world, increasing number of cases. And in February 2020, the World Health Organization designated the disease COVID-19. So COVID-19 is is caused by the SARS-CoV-2 virus. This disease has a wide spectrum of severity, from asymptomatic disease to critical illness. And obviously these stats in terms of how frequent each of these kind of categories of disease have changed as patients have become vaccinated or had previous exposure and have immunity to SARS-CoV-2. But in some studies, up to 80% of cases are asymptomatic, and critical illness, at least early on, was about 5% of cases, and that has definitely decreased now. Early on, the case fatality rate was pretty high. It's sitting at about 2.3%. And as we also saw with Dr. Jasat's presentation now, SARS-CoV-2 variants associated with varying risks of severe disease and also had an impact on the risk of long COVID. So if I were to ask you to cast your mind back to the first or second COVID wave and tell me what words kind of pop into your mind in that quite dark and difficult time for all of us, you may have a collection of words, something like this. Since the first wave in March or April 2020, we had multiple additional waves, each characterized by a different variant. And obviously today, our current daily cases are a fraction of what was reported before. But this also may partly be because of reduced testing, as well as community immunity. If we look over time at world COVID cases by region, again, since early 2020, different peaks associated with different variants, mostly this huge spike when we had this the spread of COVID again in China after all the severe lockdowns. But right today, a lot fewer cases, luckily, than what we had before. So to understand long COVID, we first need to understand the typical stages of COVID-19 disease and recovery. Generally, you have an exposure to someone who's infected. There's an incubation period, and then you develop acute COVID-19. Thereafter, you either recover, or if you are unlucky, you may develop long COVID. So if we look at acute COVID-19, we know that there's multiple different symptoms, many different symptoms that have been associated with COVID. A lot of them typical symptoms associated with a viral respiratory illness, and others quite atypical, things like the loss of smell, anosmia, or even COVID toes. Almost any symptom has been linked to COVID-19. But if we were to do a word cloud for those who suffer from long COVID or know someone who does, the word cloud may look a little different in something like this, with words like long haulers, fatigue, breathlessness, persistent symptoms, insomnia. This may be what you think about when you think about COVID. So what is long COVID? As Dr. Jasat said as well, there's multiple different terms. We use the term long COVID. I'll be using that within this presentation just because it's the most commonly used term in the lay public. But other terms that have been used before are the post-acute COVID-19, post-acute sequelae of SARS-CoV-2 infection, chronic COVID-19, post-COVID syndrome, or what is recognized by the WHO as the post-COVID-19 condition. So a little bit more on the definition of long COVID, and this was mentioned in part by Dr. Jasat. You have your exposure, a period of incubation, which lasts between 2 to 14 days. Then your acute COVID-19 disease, which would last roughly at most about 4 weeks, and then long COVID. So the development of long COVID may be a persistence of symptoms that develop during the acute COVID-19 illness, or maybe the development of new symptoms after recovery from COVID-19. But these symptoms need to be present for at least 2 months. And if you're considering the 4 weeks of acute COVID-19, this will then be for about 3 months post the onset of COVID-19 symptoms. So if we look at the definition in a bit more detail, long COVID requires a history of SARS-CoV-2 infection. This can be suspected or confirmed. 3 months of symptoms from the onset of COVID-19, symptoms that last for at least 2 months. symptoms that cannot be explained by another diagnosis, and this is very important, and symptoms that have an impact on daily functioning. As I said, these symptoms may be a new onset after recovering from the initial acute COVID, or there may be a persistence of symptoms that started during the illness. And these symptoms may fluctuate or relapse, and there's no minimum number of symptoms that are required for a diagnosis. The manifestations can be quite broad, lots of different possible manifestations of post-COVID. This particular study looked at close to 4,000 people in 56 countries. Time to recovery in this cohort was more than 8 months in more than 90% of these patients. And the most frequent symptoms were fatigue, post-exertional malaise, and cognitive dysfunction and memory problems. But if we look at the manifestations in a bit more detail, if we look here, what is in pink is the symptoms and what is in blue is the pathology. If you look at neurological symptoms, they include cognitive impairment, fatigue, most commonly disordered sleep, also insomnia, memory loss, or tinnitus. And if you look at the pathology, this may be associated with dysfunction of the autonomic nervous system, this myalgic encephalomyelitis or chronic fatigue syndrome, neuroinflammation or reduced cerebral blood flow, and neuropathies. Cardiovascular effects are quite significant. So there may be some chest pain or palpitations in terms of symptoms. In terms of the actual pathology, an increased risk of ischemic heart disease, in some cohorts over 50% compared to uninfected individuals. This myocardial inflammation, and also this paroxysmal orthostatic tachycardia syndrome, which is quite a common autonomic symptom. Respiratory symptoms are quite common. Cough and dyspnea are the most common of them, and they may be associated with abnormal gas exchange, which in some cases requires chronic oxygen therapy. The incidence of diabetes or pancreas injury is quite high in patients post-COVID, as well as the incidence of new onset autoimmune conditions. The fatigue is a very common symptom, and blood vessel abnormalities is quite a significant hallmark of COVID-19 and post-COVID. So this may be associated with coagulopathy, as Dr. Jasat mentioned, DVTs and pulmonary embolism, endothelial dysfunction, and microangiopathy, and stroke as well. And the reproductive system is also not spared from effect, within men erectile dysfunction and reduced sperm count, and in women menstrual abnormalities. So how common is long COVID? Well, if we consider the fact that there globally, up until a few days ago, there were about 770 million cases or confirmed cases. Obviously, the number of cases is much higher than this, close to 7 million deaths, and a conservative estimate that about 10% of infected people may develop long COVID. This counts to about 70 million people, and Dr. Jasat mentioned as well about 5 million people in South Africa, possibly. If you consider that 10 to 20% of non-hospitalized cases may develop long COVID and 50 to 70% of hospitalized cases, these are huge numbers. And to consider the fact that although those with more severe disease and those that are hospitalized have a higher rate of long COVID, most long COVID cases will actually occur in the non-hospitalized cases, just because those cases are far more frequent, even though the risk is much lower within those groups. So what causes long COVID? So there are multiple different theories. One is this immune dysregulation. So immune dysregulation caused by the the SARS-CoV-2 viral infection may result in persistent SARS-CoV-2 viral replication, or may also cause a reactivation of other herpes viruses like Epstein-Barr virus and HHV6. We know how important the intestinal microbiome is, and microbiome dysbiosis has been associated with COVID. And we're learning a lot more about this, but may play a role in some of the long COVID symptoms. Autoimmunity and immune priming is something we're learning a lot more about as well. The role of a dysregulated immune system and playing in heightened rates of autoimmunity may play a particular role in prolonged inflammation and persistent symptoms. As mentioned, the blood clotting and endothelial abnormalities associated with infection may result in either microvascular or macrovascular blood clotting that may be associated with stroke and ischemic heart disease. And then, of course, dysfunctional neurological signaling that may be associated with the more common and probably most prevalent neurological symptoms associated with long COVID. Dr. Jasat went over this in her study, but risk factors for long COVID, this is a meta-analysis. So what factors make it more likely for you to develop long COVID? This was a study that looked at close to 1 million patients, found that the risk factors associated with increased long COVID were female sex, as Dr. Jasat showed in her studies as well. Higher age, higher body mass index, a history of smoking, comorbidities, and then severity of COVID-19 infection. So most of these symptoms, most of these factors are actually associated with, have been well associated with severity of COVID infection. Apart from female sex, we do know that males were more likely to get more severe COVID-19 symptoms. And then if we're looking at the comorbidities, what we mentioned is diabetes, other mental health issues such as anxiety and depression, pulmonary issues such as COPD and asthma, and then chronic kidney disease, immunosuppression, and ischemic heart disease, all risk factors for long COVID. So what role does vaccination have in the post-COVID condition or long COVID? Well, 4 studies from the same meta-analysis looked at the effect of vaccination status on the risk of developing long COVID. And these showed that the individuals who had been vaccinated with 2 doses had about a 40% lower risk of developing long COVID. What about SARS-CoV-2 variants? Are different variants associated with a different risk of long COVID? And Dr. Jasat showed this as well, very, very nicely, looking at the different waves and also the odds ratio of developing long COVID. This was a different study that looked at patients that had been vaccinated, looked at duration after vaccination, and looked at Omicron versus Delta in terms of a risk of long COVID. And if you look at these odds ratios, they were all less than 1, suggesting that there's a reduced risk of long COVID associated with Omicron compared to Delta. And I think we've seen that pretty comprehensively in clinical practice, as well as in most studies that have been published of late. What about the risk of reinfection and long COVID? Does it mean that if you get infected again, your chances of developing long COVID are higher? So this study looked at a cohort of about 500,000 patients who had 1 episode of infection, and then about 40,000 patients who had 2 or more infections, and compared these to about 5 million controls, and looked at symptoms of long COVID. And what they showed was that your risk of cardiovascular or coagulation, hematological diabetes, fatigue, as well as a bunch of other symptoms, this is just a sample from the paper, showed that with an increased number of infections was an increased risk of developing long COVID. So the moral of this story is that reinfection is not harmless at all, but is associated definitely with an increased risk of symptoms associated with long COVID. That then moves us to consider, what can we do about it? What treatment is there available for long COVID? So although there are currently no broadly effective therapies, so there's no drug that you can take that's going to cure all symptoms associated with long COVID, some of the specific symptoms can be effectively treated. But there's a paucity of evidence, and as Dr. Jasat said, particularly in low middle income countries, for the effectiveness of different interventions. And a lot of the data or recommendations actually borrowed from other similar conditions as we develop more and more information on COVID, as this syndrome of long COVID and the research thereon expands. So there are a bunch of potential treatments with some supporting evidence, but as you see, most of the supporting evidence is actually from other literature with similar conditions, such as chronic fatigue syndrome or the POTS that I mentioned earlier. An example of our kind of lack of research and lack of current evidence. This is from the Pan American Health Organization. They've published a living systematic review of therapeutic options for long COVID, and looking at a particular symptom, which is dyspnea associated with, or shortness of breath associated with long COVID. What we can see here is there are only 6 current studies that have been done or ongoing, and if we look at the level of evidence and the certainty of this evidence, it's all very poor, with either very poor certainty with a beneficial effect or no significant effect. So there's definitely a need for better research that investigates treatments for long COVID. So a thorough evaluation is extremely important to identify specific symptoms that may be able to be managed. And so although there's no cure everything option, by looking at specific symptoms for which there's reasonable amount of evidence, often associated with other similar conditions, we may be able to find something that may be able to focus treatment efforts. So this is a suggestion from the Society of Critical Medicine that looks at using screening tools to detect long-term issues associated with admission to critical care facilities. And so they suggest using different screening tests like the MOCA for cognition, the Hospital Anxiety and Depression Scale for anxiety and depression, as well as a 6-minute walk test for just as an introduction to be able to try make an assessment of mobility. So in terms of a summary for long COVID, we know that it is a common condition with varied presentations and severities. Reinfection is not harmless, so COVID hasn't gone away, and there is still benefit in making sure that we don't get reinfected. So prevention of infection and severe COVID-19 is actually the best way to prevent long COVID. And more research is needed to develop treatment solutions to alleviate what is definitely a growing healthcare crisis for us and for other parts of the world as well. So when we say prevention of infection, what we're talking about is being fully vaccinated, as Dr. Jasat said as well. Be aware of community risk of getting COVID and transmission dynamics at the time, and adjust your behavior accordingly. And then the usual preventative measures of mask, hand hygiene, and avoiding closed spaces. Thanks so much.
Thank you very much. That was Dr. Lyle Murray, and he's presented on as part of the update on long COVID on a clinical and physician's perspective, and we thank him very much for that contribution. Just a reminder, please type your questions for our speakers in the question answer box. Our speakers and their background panelists will be looking at your questions there and answer it there. I see that it's been quite busy there as well. Thank you very much for that. We have at the moment almost 390 people online, and that is quite a significant percentage of the 820 odd people that have registered. So thank you all for joining. Our next speaker is Dr. Lucas Mosidi, and Dr. Mosidi is an occupational medical practitioner with 14 years of experience in occupational health, mainly in the mining industry, and having previously worked at the Compensation Fund as the Director for Medical Services. And he's currently active within the insurance medical sector. So I'm going to immediately hand over to Dr. Mosidi and thank him for joining us today and to come and share his knowledge and experience with us. I hand over to you, sir.
Thanks, Ashraf, and good morning, colleagues. So, as Ashraf has mentioned, I'm Dr. Lucas Mosidi. I'm the head of medical management at RMA. So, I think my presentation today actually has been done a lot of justice by the previous speakers. So, yeah, I'll just go straight to then the compensation aspects of long COVID. So as Rand Mutual, we are licensed to administer COIT Act in terms of Section 30 of the COIT Act. And our mandate is basically derived from Section 27(1)(c) of the Constitution to provide for social security in terms of the Act to those employees who have been injured or who have contracted occupational diseases. So COVID-19, as per the regulations which were present during the pandemic, was one of the conditions that we actually provided compensation for. So you'll understand that currently most of the primary regulations were actually repealed in June of last year. So we're currently working only on the consequences of COVID-19. So in terms of the COVID Act, the employees do have the right to compensation if they contract an occupational disease. And that right obviously is not absolute. As the RMA and compensation houses, we actually have the right to actually adjudicate on each and every claim. And then once we have accepted liability on the claim, then the benefits are actually guaranteed. So the same applies to long COVID. So in terms of section 65 and 66, for us to be able to accept any liability on any occupational disease, that disease must actually first arise out of and in connection with the employee's job. And it must actually be one of the diseases that has been mentioned in the first column of Schedule 3 of the COVID Act. And where the disease is actually not there, there must actually be proof that that disease was contracted in the course of employment. And Section 66 goes further to say that if an employee was actually employed in any work mentioned in Schedule 3 and he or she contracts an occupational disease, then we will deem that disease to have arisen out of and in the course of his or her employment. So that provides for a presumption clause unless the contrary can actually be proven that that disease was not contracted in the workplace. So currently, as we work, obviously, we are an insurance company. We do apply insurance principles, and we provide benefits just like a medical aid, even if we are not a medical aid. So there's a lot of documentation that we require from especially the medical practitioners and the employer to be able to connect any claim of a long COVID to the primary COVID-19 infection. So for us to be able to make a determination whether we accept liability or not, then we need a lot of documentation and proof to connect that long COVID to the previous compensation that was accepted, or the claim that was accepted. So long COVID, if you look at the diagnostic aspects, the previous speakers have already indicated what the long COVID is. So I'm just going to indicate some of the common effects that we know. That is just a repeat of what the other speakers have already mentioned. So long COVID does actually include a wide range of ongoing health problems, and these conditions can actually last for weeks, months, or years. And it occurs mostly in people who had severe COVID-19 illness, but anyone who has had the infection actually can develop long COVID. And people who were not vaccinated against COVID, they have a higher chance of developing long COVID as well. And those who have been reinfected with COVID as well, they actually stand a higher chance to actually develop long COVID. So there are certain people who actually do develop long COVID, even though they have never tested positive for COVID or actually have never had any evidence of infection. So those people are able to also present with symptoms of long COVID. So in terms of our processes, for us to be able to accept liability on a long COVID claim, obviously there are three key aspects that we look at. The first one is the causality, to say that the long COVID that has been diagnosed, is it as a matter of the COVID-19 which was actually acquired in the workplace or not. And we look at the chronology, obviously, as the previous speakers has indicated, when did the person actually develop the long COVID? Was it 3 months after the primary infection? How long actually did the symptoms last, and all that stuff? And then we also look at the the medical probabilities. So this basically says that all other conditions have to be excluded before that diagnosis of COVID-19 can be made. So for us to accept liability on long COVID, first, the claim must have been previously lodged with and accepted by Rand Mutual. So there's no new claim for new COVID-19 infection that we're currently looking at. We only now dealing with the consequences of COVID-19. So the people that we have already accepted liability on for COVID-19, then we can then consider accepting liability for long COVID as well. So the second condition is that the diagnosis of long COVID must have been made in accordance with the current guidelines. So in terms of the WHO, the diagnosis must at least be made 3 months after the onset of the symptoms of COVID-19 and up to at least 1 year after the infection. And they must last at least 2 months to be considered long COVID, and all the other causes, they have been ruled out. So long COVID basically is a diagnosis of exclusion. And the third condition is that the long COVID must be directly linked to the COVID-19 claim that was previously made to RMA. So we understand that people can actually get multiple reinfections after the primary infection. That's why we also look at when did the long COVID actually develop. Because in people who have now had recurrent or multiple infections with long COVID, we actually might decline liability on some of those cases, even if the initial COVID-19 was actually deemed occupational, because just like Dr. Lyle Murray has indicated that the more infection you actually get, the more chances of you developing long COVID. So when these conditions have actually been met, the employee obviously will then have consulted with a medical service provider who will then make the diagnosis in terms of these guidelines. And then that medical practitioner will then have to fill a reopening request form, because this is not a new claim, it's just a reopening of an existing claim, so that we can then only look at the consequences or complications of COVID-19. And then the medical service provider will then give that form to the employer. The employer will then submit the claim to RMA, and then we acknowledge the claim, and then we'll adjudicate on the claim. So adjudication basically means that we'll make a determination in terms of whether we accept liability for the long COVID or not, based on the conditions, what is currently known, and how the diagnosis was made, and also based on the fact that some of the conditions would have been actually ruled out. And then if once we have adjudicated on the claim, we'll then communicate the decision to the employer and the medical service provider, who will then initiate treatment as authorized. And then the employee will then undergo treatment until he reaches a stage of maximum medical improvement. And then throughout the treatment, we'll then monitor the treatment through medical reports. And once the employee reaches maximum medical improvement, then the medical service provider will have to provide a final medical report. And then as RMA will then look at residual impairment, if there's any, depending on the system that was actually affected. And then we'll assess the impairment. If there's any impairment, then we'll provide the benefits as appropriate, and that claim will then be finalized and closed. So the way we compensate for final permanent impairment is we actually look at the system first to say which system was actually affected and what are the impairments that the person has actually remained with. So if you look at long COVID, this is taken from the Americans with Disability Act, It says that long COVID is a physical or mental impairment. So physical impairment will then include any physiological disorder or condition affecting one or more body systems, including, among others, the neurological, respiratory, cardiovascular, and circulatory systems. And a mental impairment then will include any mental or psychological disorder, such as an emotional or mental illness. So all these systems that are actually assessed in terms of impairment through various tools that we use. And then once we have determined the level of impairment, we'll then provide benefits accordingly in terms of our guidelines. So just like all the primary benefits that we provide in terms of COVID, also for long COVID, we do provide the same benefits. Firstly, we provide the medical aid benefit. So any treatment that is prescribed and authorized by RMA will then be paid for. And it will cover anything, including acute, ongoing, as well as rehabilitation for what we have accepted as a liability from RMA side. And if that person is actually given a reasonable accommodation at work, is not doing all the duties that he's supposed to be doing in terms of his contract, then we're also able to pay what we call temporary partial disablement benefit. And thirdly, if that person is actually booked off completely, is not able to work at all, then we will provide what we call temporary total disablement. So we actually pay up to 75% of that employee's salary, which is payable from the 4th day of the disease until that person has actually recovered fully and is able to return to work, or is unable to return to work at all. And then in which case we'll then switch to permanent disablement. So depending on the body system as well that has been affected and the impairment that we have assessed, we'll then pay a lump sum. If the assessed impairment is up to 30% of the whole person, or will then pay pension on a monthly basis if it's 31% or more. And should that employee then pass away because of a long COVID that we have accepted liability for, then we will pay death benefits. And the death benefits will actually include funeral costs first, and then later will then pay the surviving spouse as well as the dependents of that employee. So these benefits are applicable to all the people that we have accepted liability for. So in terms of the COVID Act, once we have accepted liability, benefits are actually guaranteed. And the opposite is also true. Where we have not accepted liability, then we don't pay for anything. So I'll end here. The rest of the presentation is just the different sections and actually how we calculate our benefits and the reports that we require. But in terms of long COVID, the most important report obviously is the medical doctor's report, which confirms the diagnosis of long COVID, and then also the exclusion of other conditions. But then we also require a reopening request form, because then this is not a new claim, it's a claim on a pre-existing claim that we have already accepted. I will end there. Thanks very much.
Thank you very much. And that was Dr. Lucas Mosidi, an occupational medicine practitioner, and who is currently with the RAND Mutual Association. Thank you very much for that. I'm going to immediately hand over. We are a bit over time, and we apologize for that. And I'm going to immediately hand over to Dr. Graham Chin, the occupational medicine practitioner within the NIOH, responsible for all of the thousands of employees in the NHLS. Thank you very much, Dr. Chin. Over to you.
Thanks, Ashraf, and thanks to our speakers. In fact, I've just come on to really tie up the session with a few Q&A questions. But I must say the presenters gave a very good and clear presentation, so I won't take too much time. the NIOH, National Institute for Occupational Health, receives questions over time, and we usually bank these. And when topics come up, we like to address them because they tend to still be very topical. So maybe there's 2 or 3 aspects still that I think we just need to practically cover. And maybe if I can start with Dr. Jassett. Dr. Jassett, are there any specific laboratory tests that can confirm long COVID, a diagnosis of long COVID?
Thanks so much, Dr. Chin. We do not have any specific tests that confirm long COVID. It's a diagnosis of exclusion, so you have to look for other reasons for the symptoms. And because the symptoms are so varied, the kinds of tests that a medical doctor or clinician might do would be quite varied as well. I'm sure Dr. Murray can say a little bit more, but as you can see from the definition of long COVID by the WHO, if a person has had confirmed or probable COVID in the past, and then they develop persistent symptoms, one of the many symptoms that have been recognized, then they would be considered for long COVID as long as you excluded other causes. But yeah, I mean, I think that the kind of diagnostic test you would have to do to exclude other causes will depend. If it's respiratory symptoms, you do chest x-rays and lung functions. If it's neurological, you do neurological tests, but there is no definitive diagnostic test for long COVID.
Okay, thanks. And maybe if I can bring Dr. Murray in. Dr. Murray, from a physician's perspective, is there any value in doing a PCR at the time you're trying to make a diagnosis of long COVID? Time has passed now. Would it still be positive? Is there value in that?
Yeah, thanks for the question. No, there's no value in that. I mean, generally your PCR will be negative quite soon after infection. And I mean, sometimes it does stay positive for patients with severe infection. I mean, we've seen some cases of it staying positive for a long period of time, but there's no real value in doing a PCR at a later stage. There is this, one of the theories of long COVID is this persistent replication of SARS-CoV-2, but it hasn't really been shown in most cases. So no, there's really no value in doing that at a later stage.
Dr. Murray, maybe while I have you on, and maybe on that topic, it's a common practical question also that we get is, can you transmit COVID-19 when you've been diagnosed with long COVID? Is it safe for you to go into the workplace?
Yes, it's safe for you to go into the workplace, and no, you can't. You can't transmit COVID-19. So for the same reason that you're not going to be able to pick it up on a PCR, most of the time the evidence of active infection is gone. So you may have an antibody response like that Dr. Jassett mentioned, that would indicate a previous infection, and it is difficult to kind of differentiate between previous infection and vaccination, but with some advanced antibody tests you can do that, but not necessarily ones that are commercially available. But no, so you generally, the period is as if once you've diagnosed, you've been able to make the diagnosis of long COVID as per the WHO guidelines, that you're really 3 months down the line, and it's very, very unlikely that you're going to have any persistent infection and any chance of transmitting it to anyone else.
Thanks, Dr. Murray. Maybe Dr. Jassett, sorry if I can come back to you just in terms of the study. Can a person who had asymptomatic COVID-19 develop long COVID? I don't know if you studied those people.
I mean, potentially they can. So anyone who had previous COVID and then goes on to have like symptoms, they can be new symptoms. They don't have to be persistent symptoms, can meet the definition for long COVID. So the studies overwhelmingly show that people with more severe disease were more likely to have long COVID, but that doesn't mean that people with mild disease couldn't. I mean, quite large numbers of them do develop long COVID just because most COVID disease is mild. I haven't seen many studies specifically on asymptomatic cases. Dr. Murray, do you have a better response?
No, just that we do know that asymptomatic infection can be associated with symptoms later on. The issue is obviously trying to prove that when the absence of symptoms at the time. But yeah, so some studies that have looked at long COVID have shown that there is a possibility of developing long COVID symptoms, even in those that are initially asymptomatic. But as you say, all of the studies show that the more severe your acute infection, the more likely you are to develop long COVID. And most severe cases of long COVID are associated with more severe acute infection. Although, like I said, in terms of total numbers, the majority of cases may actually be people who had mild infection initially. It's a kind of a bit confusing in that way, but I hope it makes sense.
Perfect. And just maybe one last question for Dr. Mosidi. How do you determine if COVID-19 was work-related or in the course of employment, like Section 66? How does one generally, are there some guidelines that can give us? How do you make that relation to this was contracted in the workplace and not at home? We saw so many cases being transmitted at home.
Yeah, thanks, Dr. Chin. So you would understand that previously we had the regulations that actually gave guidance in terms of how the workplace acquired COVID-19 can actually be determined. So one of the key aspects was a sentinel case. You know, we needed to have an employee or a colleague who also has been actually diagnosed with COVID. And that employee who's now claiming for compensation must have been in contact, you know, with that person, you know, with the conditions that were provided at that time. There was an issue of a distance and the wearing of masks as well, you know. So the risks that were determined at that particular time were the
sentinel
conditions that
case.
Yeah.
The sentinel case is the key feature.
Is the key feature, yeah.
Okay. And Dr. Mosidi, sorry, just one last question, and then we'll probably end off there. Should every COVID-19 work-related case be submitted for a claim?
Yeah, currently, because we're only dealing with the with the consequences of COVID-19, we only then will accept cases that we already have on our database. No new cases can actually be submitted. So the employer, before submitting, he actually needs to also indicate the claim number that has been provided to him in terms of that claim.
Sure. I think we're
Graham,
a little bit
just
over time,
one
but I'm going to end there.
Yes,
Thank
can you
very
hear me,
much.
Graham?
I can
There
hear
was
you, Ashraf.
Is one open question in the Q&A box that Dr. Mosidi just wanted to answer live. Dr. Mosidi,
okay.
just want to take a minute just to answer that question in regard to COIDA in the Q&A box?
Yeah, so basically the question is asking if there are no objective functional or anatomical impairment that can be assessed, but the person is actually struggling with some aspects of work, whether we can actually compensate that employee. So unfortunately not. There need to be something that we can actually measure and turn into a percentage of impairment. So if we don't have that, then we won't be able to provide compensation in terms of permanent disablement. But if that person actually needs ongoing treatment, then we can approve ongoing treatment related to that condition.
Thanks, Ashraf. I'm going to hand back to you. Thanks, Dr. Jassett, Dr. Murray, and Dr. Mosidi.
Yes, thank you. And that's thanks to Dr. Graham Chin as well for handling that Q&A session for us. And to conclude, we've had the highest, I think, about 400 people of the 820 that have registered that was live in the session. We thank you all for joining us. This was our webinar as an update on long COVID. And I need to also just add my voice in thanking our three speakers, Dr. Wasila Jassett, Dr. Lyle Murray, and Dr. Lucas Mosidi for their contributions, taking the time for preparing and contributing today, as well as our non-speaking panelists. And I will start with them as I have them here in sequence. Dr. Edward Supirwa. I've already mentioned Dr. Graham Chin, Dr. Shlonipili Maso, Dr. Nompumelelo Ndaba, Ms. Zandile Hoyi, Dr. Yarumia Ndombi, and Sidiso Masongwane. Thank you very much for your work in the background. And then finally, but not least, Tabani Zwane, our IT colleague, who's done quite a lot in the background to make sure that this session happens and runs smoothly, and that all the post-webinar aspects are dealt with. And as a final reminder to our attendees, yes, you will all receive the general certificate of attendance. You will also receive a link to the multiple choice questions for the online CPD test for those who requires it, and all the links to the presentations and the video recording for the webinar. Those links will also be circulated to you, all those who have attended this webinar. At this point, I say thank you very much to our speakers and the NIH team, and we will say goodbye. Please enjoy your end of year closure and stay safe until next year when we reconvene with our webinar series on occupational health and safety and critical issues. Today, you've heard the important aspects of long COVID and how that relates to our workplace. And as the functionaries, employees, health and safety reps, shop stewards, health and safety officers, the nursing and doctors, and other people responsible in the workplace, please let's keep ourselves and our fellow employees safe. Good day. See you on the next webinar.